we are across the globe, London, Australia, here in the US. And it was just vital to take the experience that was painful because I was a healthy, fit mom, and I lost my job. I was just turning 41, so it was impactful. I felt like I was 80 overnight, basically. So many people lose their livelihoods, their sense of self as they know it. So we decided to create a place that would investigate ANOCA, which is angina with non-obstructive coronary arteries, and it's not as rare as people think. There's way more to heart disease than obstruction, and I just my difficult journey and we turned it into doing something about it.
Organization that provides peer-to-peer support for women with heart disease, which is very needed, and I can say that because I am a heart patient myself. I'm a heart survivor. When I was 46 years old, I had a heart attack, and so I've been living with heart disease all those years, and about 15 years. And so, but Women Heart also is international. We do advocacy work. We also do sport education and awareness.
It starts with you. It starts with taking care of yourself and making yourself a priority early in your life. We're kind of counseled and educated in our society that we're too busy, right? We're too busy to take a day off to go see the doctor. We're too busy to stop when we're chasing our children or when we're trying to keep up with our jobs. And then we're kind of forced to stop when something happens. So I would say let's start with taking care of ourselves and prioritize.
I'm Cherry. I'm currently in the long path of cardiology training with specialization in interventional cardiology, like you mentioned, and critical care cardiology. I'm at Penn Medicine, but I was fortunate to actually train with Dr. Crabb in my early training at Temple. That's a great question. I think, in taking care of patients who are presenting in all different types of ways with heart conditions, we actually, I think, have more information and experience relative to other parts of cardiology with regard to patients presenting with acute severe heart attacks. So when people come in with like acute blockages of coronary arteries, they're more likely to be presenting with chest pain compared to some other symptoms, and that's for both men and women. And they're more likely to be presenting with things like high heart rates, low blood pressures, other indicators to us clinically that something acute, critical, and life-threatening is going on. So unfortunately, there's then patients who are presenting maybe with not those more high-risk features, and so then we start to lose some of our triage ability because we don't see those markers that are flagged in the chart as this heart rate is high, it's showing up red, or this blood pressure is low, things like that are putting off our sort of red flags as healthcare providers. And so there are a lot of gaps throughout the system, but in both patients recognizing what's going on with themselves or that something is off and presenting to care, but also in how quickly we are triaging patients to the appropriate acuity of care and the appropriate next steps and interventions. So it's challenging, but I think we are lucky in some ways to have a lot of indicators that something severe is going on, but that's not always the case.
And thank you very much for inviting me for this very, very important panel. In order to answer that question, I have to tell you how I came to be a cardiologist. And I came to be a cardiologist because I started to get, particularly in women's health, because I became interested in around 1990 what was happening on the world stage. And what that was is, it was becoming more and more clear that women had been excluded from the research enterprise and understanding heart disease. A very famous paper came out in the 1990s era in the New England Journal talking about the number of cardiac catheterizations and interventional procedures that were done in the country, and women with similar symptoms as men had less cardiac catheterizations than paper caused a lot of controversy because physicians don't want to believe that they discriminate or incorrectly identify patients, but the data really became more and more reproducible as more people looked at it. And then I got interested in the impact of that in the minority community, and we found the same exact things. So when I came to make a choice about becoming a cardiologist and going on with my training, I decided I wanted to come to a community that number one, really needed me. And I came to Temple. And Temple is a unique place because we do a lot of hard things at Temple. We take care of a community of about 500,000 people. 46% or so, 50% are women. These women are often involved in single-family households, so they're the breadwinners, they're the matriarchs. These women have, the community of Temple has about 43% hypertension. And African Americans, in the African American community, hypertension is a really important risk factor for future heart disease. These women live at the poverty level. To add insult to injury, they don't have access to healthy fruit and vegetables. They don't have access to places to walk and exercise. And then the part that really became apparent to me is that they don't understand all of this stuff that you guys are talking about. In other words, when they get sick, the impact is great because they are the matriarchs of their families. And most of them are getting sick in their mid-50s. Now, in your mid-50s, in the United States, I mean, we have a president who's in his almost 80. We've had people in Congress in their 80s living productive lives. And these women are being struck down in what I consider to be the prime of life.
With curiosity, being open to not developing an adversarial relationship with those that have a duty to care for us. And Robin, you have experience as a RT, but also Rose, when patients come to you to have these important conversations, what are some things we can do so that we do not put our clinicians on guard and
I think it's a two-way street at all times. When we're having that dialogue with the patient, there's a lot of time constraints with us. Thank you. There's some unfortunate time constraints with us in many of our offices. Fortunately, in my clinic, my director has allowed me to have an hour with the patient, so I can spend quite a bit of time and dig a little deeper and learn about their kids and learn about their hobbies and things like that. What's important to them and how we can get them back to that. I can spend the time to educate about the medicines, because you're right, we can say, here, take this, but if they don't understand the why, right, that's the other half of the equation. Like, we can only do 50% of the work, right? Like, the patient has to meet us halfway. And
Explain what a champion is. First, a champion is a woman with heart disease who comes to our organization, and we train them at the Mayo Clinic in a 3-day extensive weekend how to advocate for themselves, how to be able to start support groups in some of these areas that really need, women do need support. It's very empowering.
I think, fortunately, I think that as we learn more about the disparities in, cardiovascular disease and the care that people are receiving, I think my generation of doctors in training is actually getting a much better education in how to recognize, critical scenarios that might be going on, and also how to recognize and appreciate that there can be disparities in care and how to avoid those things. I think it might be harder for doctors who have been in practice for a while, who have learned something that was taught a decade or more ago, to sort of relearn or even be confronted with some of the statistics about the disparities in care and to be able to address those things. So I think the educational initiatives need to not just be with new doctors, right, but also like doctors who are in practice, with healthcare providers of all backgrounds, on research teams, thinking about how we can be asking questions, how we can be reaching patients better, really asking the question like, where are we failing, like in your, someone in front of you, like in your case as a patient, where could we have done better? And really thinking about individual stories and using those anecdotes to help identify gaps. I think.
Those testing more portable and available in the field, we can triage earlier, right, and appropriately bring people to the right hospital that has the therapy that the patient may need. I think it all comes down to education. When I started as a paramedic, AEDs were just becoming a thing in the community, right? I know, I'm old. Right? We were doing CPR as 5 compressions to 1 breath, and we saved a life, and then they said, well, we can do better. Let's do 15 and 2, and let's do 30 and 2. We tried all different kinds of things, and now we're just doing compressions only, right? So like we're still learning, and I think that's part of this, is that we're still evolving as a science. We're still evolving as providers, right? And updating our own education. Our education models have changed, particularly after the pandemic.
We recognize that, first of all, the women themselves don't realize that heart disease is the #1 cause of death. That's a problem because it prevents women from seeking care. Breast cancer became very, very prominent in the news, and rightfully so. It's a horrible condition. But it got prominent because, if you remember, now 30 or 40 years ago, we had a first lady who had breast cancer. That's Betty Ford. And so breast cancer really got up there, and heart disease didn't. So a lot of people started to think about that. So we had some public health campaigns. Many of you have seen them or maybe participated in them. Go Red for Women, Heart Truth, etc. And we noticed that in the mid-2000s, the awareness of heart disease among women improved, although minorities it lagged. And in the last 10 years, we've lost ground in that. And surprisingly not, minorities have lagged in that too. So we have an awareness gap. The second thing, I think, with regards to the innovation for maternal health, we find ourselves in a maternal health crisis. We have the worst maternal health statistics in an industrialized nation. And guess who suffers the most? Minority women. And there hasn't been enough research on the conditions that are cardiovascular that impact the outcome. We didn't know until recently that if you are pregnant and you have what's called an adverse pregnancy outcome, you have a preterm birth, you have a stillbirth, you have a ruptured placenta, things like that, that is almost a red flag for future heart disease. Women don't know this. Women on average don't know that preeclampsia is a risk factor for future heart disease. In the last 10, 15 years, there have been a number of papers that have come out showing that if you've had preeclampsia, you may have subclinical coronary artery disease. So this information is not readily known in the general population, and therefore they don't seek health care. Second thing I would say on the providers responded. In the 30 years I've been in practice, I've gone and done multiple talks in this area. I've done national talks. The healthcare providers respond because why? It's already been mentioned. 51% of the people that walk in their office are women. And they do want to take care of their patients well. I don't think people enter this thinking they want to do bad medicine. So they read and they go to meetings, and women's health topics have increased in national meetings. Women's health research has increased on a small level. But we have so far to come because we have been not invested in for so many years. Now we have a lot to do. And now we're in the middle of the maternal health crisis. I'd like to give you one statistic that is a staggering statistic, and it's a Philadelphia statistic. 46% of the pregnancy-associated deaths in Philadelphia are related to cardiomyopathies. Did you know that? Because I didn't know that till I looked it up. And what is the most prominent cardiomyopathy? It's peripartum cardiomyopathy, which is a cardiomyopathy we see as women during their pregnancy. It's usually seen in the last month of their pregnancy up until the first 5 months of their pregnancy delivery. Most women do recover, 50% recover, but there's a sector of women who have severe LV dysfunction or severe heart function who may not recover or can have adverse outcomes so bad that they need Rose's help. There's data about how to treat these women, but there's small studies. There's data about heart failure in general, but there's no specific data on how to recover a woman's heart when they get this condition that's definitive, that's our highest level of evidence, which is a randomized clinical trial, until recently. The Rebirth trial has been in existence now for 4 years. I'm happy to say it's we are one of the sites. Penn is one of the sites. And we are trying to get women into this trial so we can determine whether bromocriptine can be used as adjunctive therapy to help rescue the heart. And guess what's happening? We're having trouble enrolling. The women don't understand. In our community at Temple, where we have the precursor or the risk factor that's very important for developing this condition, which is preeclampsia. We have tons of preeclampsia. We can't get the women to understand they need to enroll or consider the trial. Of course, we can't force anyone, but consider the trial and get them to come back for their basic care. Busy moms, lots of stuff, so they really need help and tools. And the care of women's health needs to be a package. And we need to be talking about things like models of care. How do we deliver the care? How do we take into account some of these shortcomings, some of these limitations, to make it easier for women to access care? Plus, menopause being around age 51. So if you're in your 60s and 65, they're expecting you to have heart disease. But when you're 46, not so much, okay? So part of it is a lack of understanding that, for instance, many years ago, there was a statistic that put out that while that fact I just told you is true, about 10,000 women in the United States at the time, under the age of 45, had heart attacks. So it's not impossible for a 46 or 45 or 50-year-old woman to come into an emergency room with chest pain or not chest pain and be at risk for having a heart attack. The classic heart attack symptoms are angina. The descriptors are a male-specific descriptor. Now, that being said, women also complain of the same things in the way men do. It's pressure, heaviness, tightness, squeezing. It may be a burning sensation. The pain may start in the center of your chest, but anywhere from your jaw to the upper portion of your tummy is fair game. Can be right side, can be left side, can be in the center.
Could be in your back.
Could be in your back.
A knife in the back.
Yeah.
It will radiate down your arm. The radiation down your arm usually is on the inside of the arm, but I have plenty of people who tell me it's on the outside of their arm. That's why being a doctor, a healthcare professional is not easy, okay?
So it can have that symptom to it. It usually will have a progressive kind of development, but not always, because sometimes people don't recognize it, they blow it off. So they may notice that over several weeks or several days before, the pain gets worse with walking, exertion, it lasts longer as the weeks go on, and then eventually it just doesn't go away, and you end up it gets your attention, you go to the doctor. But we've had many people who've come in too that say, I was fine yesterday, and last night I woke up with this heaviness in my chest. I didn't know what it was. I thought I should come to the hospital, and they have a heart attack. So we're humans. There's a variation in all of us. There's a variation in the presentation. That's why it's hard to be a doctor. You got to take good histories. Histories are everything. Not AI. I'm sorry. I love AI, but not AI. It's still talking to people and getting a good history. So those are the symptoms. Now, how are recognized to have atypical presentations? For instance, the presentation that Robin had of only the arm pain, or maybe only shortness of breath, or maybe they only feel funny and they feel unwell and they're nauseous. If they're of the right age and they have the right risk factors, heart disease is still a significant cause of morbidity and mortality in the United States, they should be considered and it should be ruled out.
Dr. Crabb mentioned shortness of breath, lightheadedness. For some people, it's like a sense that something is just really wrong. Like, I just don't feel right. It's hard to describe. I don't know why. Something just feels wrong. I think I would encourage people, if they feel like they're not being taken seriously, or they're worried that something's being missed, or they have symptoms, they're just like, I'm concerned I'm having a heart attack, to say that, to say, I'm worried I'm having a heart attack, and to like ask for an EKG. As we mentioned, EKGs aren't always perfect, but in most cases, if you're having a massive heart attack, an EKG is going to show that. And that's the first step. And I think it's reasonable to say what you're worried about. Unfortunately, for a lot of women presenting with symptoms and saying, I'm worried, there can be additional bias of thinking, oh, this is anxiety. But if you name what you're worried about and you ask for care that you think you need, I think that people ideally are not denying you that and are saying, okay, this person's having these symptoms, they're nondescript, but they said they're worried they're having a heart attack. Honestly, a lot of times in our, in the clinical setting, if someone's like, I just feel off, something is just off, like that raises red flags for me as a clinician. Like, I'm worried, right? I don't know what's going on with this person, but if you're just telling me I feel horrible, something is really wrong, I feel like something's really wrong, that's making me nervous as your doctor, and that's making me want to figure out what's wrong. So I think naming those things and asking for what you need are valuable.
Yeah. And to that, the way we are educated is to ask the right questions, right? Try and drill down to the symptoms, but then as we're hearing it, we're already kind of coming up with a plan, like, okay, well, chest pain, heart attack, like we want to rule out all the things that can kill you first, and then the differential is what we call it. When your symptom is fatigue, the differential is the whole room, right? So it's really hard to drill that down, or I just don't feel right? When was the last time you felt well? And sometimes it's so slow and insidious that they don't remember when the last time they actually felt well. Like, I've had patients come into our clinic and they are so massively fluid overloaded that we bring them into the hospital and we'll take 50 pounds of fluid off of them, just fluid, and now they're walking around the hall and they can breathe, and they haven't been able to do that in a year, right? So like, sometimes it's slow and insidious. The point that we make is we want to rule out the thing that's going to kill you right now, and that's specifically what the ER specialists are looking to do, is rule out the stuff that's going to kill you right now. But also,
My tell, in poker, somebody's got to tell. You can always tell when they're lying or they're bluffing, right? So my tell is my left arm pain. I never really have a lot of pain in my chest so much. My tell is also shortness of breath, but mainly it's my left arm. When my left arm goes tingling on me or in pain, I get my butt to the doctor, or I think about going to the doctor, or the ER. It's
or
like, or whatever. So, and then I go. But when I do present myself to the ER, if I go in there and say I got pain in my left arm, they're just gonna look at me and go, okay, go have a seat. But when I walk in there, I say, I'm having chest pain. I'm having shortness of breath and I'm having chest pain. Now they're taking me serious because I'm using a man's symptom. And now they're taking me serious. But fortunately for me, the ER I present myself to all the time, they know me. They know I have 17 stents, so they take me serious.
And I wanted to introduce myself first. For those who don't know me, I'm Melly Chow. I am a entrepreneur turned engineer turned entrepreneur, operator turned venture capitalist. I am a venture partner at Archangel Axiom, which is an early stage Canadian IP-based fund. We over-index on medtech, biotech, and health tech. 27% of my portfolio is female founders, we're proud of that. And I'm joined today with Sahar Jalil, and we're going to talk about Dr. Sahar Jalil is the founder and CEO of Lucentia, an AI-powered medtech company pioneering the next generation. She brings deep expertise in medical imaging, mechanics, and translational technologies across cardiovascular and respiratory systems. Sahar earned her PhD in aerospace engineering, which is actually where I started as well. So I love that commonality, and maybe it does take a rocket science to get femtech right. From the University of Minnesota, specializing in fluid structure, interaction, and advanced imaging methods. She later completed a postdoc fellowship in radiology at Weill Cornell Medicine and New York Presbyterian Hospital, where she led 5 years of NIH-funded research that produced one of the world's most comprehensive ex vivo cardiac data sets. As a lead innovator on multiple patents, she's developed proprietary imaging methods and unique data sets that now form the scientific foundation of Lucentia. And in 2025, Sahar founded Lucentia with the mission of reinventing how coronary artery disease is detected. Under diagnostics, products and services that use technology focused on women's health, including menstruation, fertility, pregnancy, menopause, and general health issues that disproportionately affect women. The term was actually coined in 2016 by Ida Tin, a Danish CEO and co-founder of the period tracker app Clue, to empower the sector and make it easier for investors to identify this. And I actually had the pleasure of meeting her last year at Toronto Tech Week, and she's a speaker as well. And so femtech is really now focused on 4 areas, including diagnostics and AI, menopause, endometriosis, therapeutics, B2B, employer distribution type of solutions, where cardiovascular disease, for example, in women, symptoms are often less clear-cut, as you heard earlier from our panel. And hypertension or diabetes, and they tend to have more complications. And as a result, they're recognized much later. During a heart attack, only 29% of women receive an ECG within the recommended time frame, compared to 38% of men. Just 32% of women receive timely perfusion therapy, compared to 59% of women. Moreover, early signs of heart attack are missed in 78% of women, delaying recognition and treatment. And so today, women's heart health is one of the largest underdiagnosed, underfunded opportunities in healthcare. And we're going to go from her founder why, building, funding, and what it takes to win in this space. So with that, I'd love to start off with your origin story.
Yeah, well, first of all, thanks for having me. Super excited to be here. Origin story, I think you mentioned a lot of it in your intro, which is really kind. Thank you for that. I'm born and raised in Morocco. I've done a lot of research all throughout aerospace, fluid mechanics, imaging, and during my postdoc at Weill Cornell, New York Presbyterian, where I was dissecting human hearts for a few years. This was our unique approach to imaging. We had these protocols and methodologies that we developed over 5 years and patented. But during my postdoc, I lost my dad unexpectedly to a silent heart attack, which obviously shifted my perspective on translating some of the technologies that often stay in the lab, don't make it out, and don't really impact in the same way. And that sense of urgency led me to finish my postdoc, move to Paris for a few months actually to join an accelerator program called Entrepreneurs First, and where I built some of the collaborations with some European hospitals before moving back to the US in San Francisco first, and then New York City, where I'm building Lucentia. So that personal story is really what drives I would say the company, myself, the team, and we are building with that mindset because as we've heard throughout the whole day-to-day, it's not just men, women, but there's also different symptoms from across different ethnicities, different people, and they never make it to this gold standard diagnostic, which is the CCTA, coronary computer tomography angiography. And it is the #1 recommendation by the AHA for folks who present with chest pain, which again is a very male specific type of symptom.
Yeah, I love
We have all the downstream solutions that are being built. I'm sure folks are familiar with HeartFlow, for example, or Clearly, which comes from the same lab that we came from at Weill Cornell, or Elucid, which is another company. They all use this CCTA as an input, and they give you even more information, whether it's functional assessments, for example, how well your heart is beating, through FFR measurements, or structural assessment, which is now very, very important. And we just have a new code created for plaque assessment that reimburses up to $1,000. And so that essentially tells you what kind of buildup you have. Is it early stage? Is it middle stage? Is it late stage? But we really don't have a way to unlock that for everyone. So similar to it, that's why I call it the mammogram of the heart. For breast cancer, you have mammograms. For colon cancer, you have colonoscopies. What do we have for heart disease that is consistent, that is scalable, that gives you the full spectrum? Well, we have CCTA, but it's not scalable. We have calcium scores, but they're not comprehensive.
So we talked a lot about that today. How if you have underlying autoimmune disease like lupus or RA, you can have elevated risk factors for having heart disease and having this ghost disease that you don't see until you have a heart attack. So throughout my career in oncology, we've seen all these drastic changes in cell therapy. And a couple of years ago, we decided to use CAR T-cell technology to see if we can treat heart disease with it. So Cardio is a spin out of Penn, and we've been using cell therapy to try to treat atherosclerosis. We're in our early seed stages, so if you're interested in investing, we'd be happy to talk further.
Hello, my name is David Zabrowski. I'm the founder and CEO of Gencardia. We're a startup biotechnology company developing RNA-based therapies to treat heart failure. As you know, most heart failure medications just treat the symptoms of heart failure, not the actual problem of the heart failing. So what we're trying to do is target the molecular mechanisms, the genes that are responsible for why the heart isn't pumping or relaxing appropriately. We have 2 programs, and just to give you a little bit about what people look at in this therapeutic space is our lead program is dealing with cardiac stiffness. So more specifically, cardiac relaxation between beats. This underlies what's called HFpEF, which is disproportionately seen in women and has no therapeutic options that modify the course of the disease. The other thing, the second program we're looking at, we're dealing with or addressing cardiac metabolism, and more specifically when cardiac metabolism goes awry. And this underlies almost every form of heart failure, including HFpEF. And the mechanisms underlying why cardiac metabolism goes awry is likely different between men and women. So how you develop a therapy, you gotta be conscientious of this. So these are our 2 main therapies. I love to talk about heart failure. I love to talk about our mission. So if you are curious about what we're building, or where we're heading, or if you have any insights, or while you're sharing stories, feel free to grab me or contact me in the future. So thank you very much.
What's HFpEF?
Oh yeah, So HFpEF is an acronym. It stands for heart failure with preserved ejection fraction. So there are two main forms of heart failure, or largely classified. One is where the heart cannot contract properly and pump blood to the body. We call this HFrEF, heart failure with reduced ejection fraction. Just it's not pumping much of the blood to the body. HFpEF, which is preserved ejection fraction, the heart can still contract, but it can't relax properly. So it doesn't fill with much blood. So it does contract, not much blood goes to the body, hence the heart failure.
Thank you.
Yes.
Everyone, my name is Kuhn Vendischer, and I'm co-founder of Angiomedics, together with Dr. Smit Shah from Yale University. At Angiomedics, we're trying to address one of the big blind spots in cardiology, which is ischemic heart disease when you don't actually have plaques. So this is what Annette was describing earlier today. Based on years of clinical research under Dr. Smit Shah, we're working on a pharmaceutical diagnostic that you can use during cardiac catheterization, which actually gives a very accurate and real-time diagnosis of what is going wrong. Unfortunately, for this diagnostic procedure, only around 10% of cardiac cath labs are able to do this test, and a big bottleneck here is the pharmaceuticals you need to do this testing are not widely available. So we're currently working on reformulating these drugs specifically for this indication so that it can become much more standard of care and provide a diagnosis to the millions of women having these conditions and give them a diagnosis when they have persistent but often, again, undiagnosed symptoms of heart disease.